this lecture will apply just a little bit better. It's how can we get better with data? I'll use hipospadias as an example because obviously that's what I'm most familiar with, but it applies to anything that you might do. So the first step in getting better is knowing your own results. One option to do this, of course, is a retrospective chart review. That's what most people do. You have a question, you get a stack of 200 charts, and you go through them, and you find out what the answer is. But the problem with it is that there can be data that's missing. You can't find some patients. There might be lost information. It wasn't listed in an op report what technical step was done or not. And so there are lots of blank gaps to fill in. And one of the worst problems about it is that once you've done that whole review and all that work, you've only answered that one question that you went back through those charts. You can't answer new questions that might arise with it. So a better option in that standpoint is to keep a personal database. It's actually very easy to configure and maintain. This is one of our original databases, which looks a lot scarier than it has to be, and I'll show you how to make it a little bit better. But you'll see that the information, once you start to use it, is much more complete. You can instantly know your results. And then if you have a new question that arises, you just add a column, and you can know your results for that as well. So let's talk about the creation of a quality database. If it is for hipospadias, what do you need to keep in it? It's very straightforward. You need a name or a number of the patient. You need what surgery you did. For us, it's a distal or a proximal repair. They had a tip or a stag. And you need whether it was a primary surgery or reoperations, because reoperations always have higher failure rates. And then when they come to see you at follow-up, you need the date that they saw you and if they had a complication or not. That's it. You can do it in just a few minutes. If you happen to take your computer, or even on your phone, you can get an Excel spreadsheet if you password protect it. And very quickly, you'll know. But the most important thing when you're setting your database up, if you're going to start it from scratch, is that you need to know what your outcome is. So for us, it's urethroplasty complications, but it could be stone recurrence rate. If you're interested in hernia repairs, it could be hernia recurrence. It could be margins or PSA. Anything it is, but you need to know what your definition of your outcome is before you start, because if you don't, then your data is not very helpful to folks. Once you enter the data, you can do it after surgery or when they're there for follow-up. It really begins to take just a few minutes. And the nice thing about it is you'll realize it's helping you standardize your technique, both during your surgery when you're entering those few data points and at follow-up when you ask them questions. Have you seen them pee? Is it one stream? Is it two, for instance? Because you want to put that information in your database. So this is that 3P concept that we talked about. You can keep the database, you can periodically review it, and then you can make practice changes, because I can guarantee you that it's never quite as good as you think. So I'll give you just one example of ours, glans dehiscens. That's where the head of the penis opens up and essentially the child still has distal hipospadias, or there's a bridge of skin but the glans wings themselves aren't together. It's our most common complication that we see, but we couldn't find anything in the literature to try to look for techniques that people use to fix it or to prevent it altogether. What we did know from our data was that it was 3 times more common in patients with proximal hypospadias than in distal hypospadias. So we thought, okay, well, here's a clue. Let's see what we can do. That was despite having the same surgery and using the exact same surgical technique. So we knew it wasn't that aspect. There was something different going on. So what we hypothesized was that it was because the glans was smaller. And so we got calipers out and rulers out, and we measured a lot of penises. What we found was that actually that was true. Patients with proximal hypospadias have smaller heads of the penis than kids with distal hypospadias. That's not a big surprise. So we thought, okay, this is easy because we can fix that. We can give testosterone. And so we were the first group that actually had objective numbers and objective reasons for giving the testosterone with an outcome of growing it to 15 millimeters or larger. What we found is that by using objective criteria, the use of testosterone doubled in our hands, meaning we had missed a lot of kids that our eyes didn't tell us had a small penis, but actually they did. We also found that when we gave the standard dose that people report, that 2 milligrams per kilogram, it was insufficient for the vast majority of kids with proximal hypospadias. We had to go to higher doses in order to grow the penis to the size that we wanted to achieve. But most importantly, at the end of the day, we weren't worried about penis size. We were worried about whether or not we solved a problem, and we were not very happy to find out that we didn't. Because the patients who got testosterone, we grew their penis to where we wanted, but they had a higher rate of complications when we did it. And the whole goal was to reduce complications in these patients. So now we no longer use any testosterone because it doesn't help the patients. And actually, there's no data in patients with proximal hypospadias that testosterone benefits them. Zero. Doesn't exist. So you can see that a database, within a very short period of time, all of those findings with size and testosterone use happened within 1 year, and with the complication rate within 2 years, we knew that we totally changed our practice to help these kids have better outcomes and not be harmed by the things that we were doing to them very quickly. So let's talk a little bit about a database. When Dr. Snodgrass started it in Excel, he put a bunch of words in. So, it says 7-0 vicral and distal and proximal, lots of things, so you can see it looks very complicated. So when I came on board, I had more than 1,000 patients that I had to totally recode. It takes a lot of time to do that. So if you're starting one, it's helpful to kind of get it right from the get-go, make it easy on yourself, easier to put the data in and easier to get the data out. And you can do this with something that's called dummy coding. What is that? Well, it means you're going to give numbers to things instead of typing stuff out. It makes it way faster now when we enter our data because we just do zeros and ones and twos for things. So these are some examples, but you could do the same thing for prostate cancer or BPH or stones or anything else. You just need to know what the codes are. The most important issue, though, is going to be on your outcome. Whatever you decided your primary outcome is, you really want to label that with standard computer code, 0 for no and 1 for yes. And then within a second, you just go to that little box at the top of Excel that says an E, a sum, and you can just highlight that column, and you will know instantly how many complications you have. It's really that straightforward to know. So you put the data in, it gives you a lot of flexibility for knowing your results, and then if you want to take it to the next step like we have with logistic regression to get the nuances of things, you certainly can do that. So we've determined multiple risk factors or non-risk factors doing that age doesn't matter, that gland size does matter, that testosterone does matter, that erythroplate size doesn't matter. These are just some of the things that we've been able to do. But it's not just us. It's actually worked for many folks that we've given these lectures to when we've traveled around the world. Multiple examples of it. And they all say the same thing. You were right. My results were not nearly as good as I thought. It's the same thing we find every time we look at it. But I've gotten better now because when you see that your results aren't where you want them to be, your mind is open to thinking about what the technical steps are that you can make to make life better for your patient. And that's what all of us want to do. So it actually makes it very exciting to go to work, to think about really technical steps, things that are in our control that we can do to be better surgeons. So when we do this, the message for all of us is that this can change your practice. If you want our template for hypospadias, I've shared it with many folks. Just email me. Here's my email address. I'm happy to share it with you. Here's just a few samples of the papers. Everything that we've done in terms of technical modifications has come from our database. All of the data that I talked about earlier and what we'll talk about this afternoon, it's come from the database. All the questions that we have yet to ask and answer, they'll just be a new column in the database. So at the end, there are a lot of lessons, I think, for us to learn from how important it is to just pick one thing that you really like That's it, just one thing, and keep up with it. And think about how much better the surgical world would be if all of us just chose one thing, got better at it, and then told other surgeons how to do it so that they don't have to experiment or start doing the bad stuff. They can start up here doing the good stuff. It takes very little time to do. You can standardize the surgeries that you do, which actually makes it a little easier on you. It makes it easier on your nursing staff. It makes it easier on your trainees. Very rapidly, in real time, you can see what your results are. You've got complete data. You don't have all these missing blanks like you do in retrospective chart reviews. You can easily ask and answer new questions that arise as they come up. And certainly, you can increase your academic productivity. But at the end of the day, the most important lessons are that if you can keep up with your data for even just one condition, you can make your surgery better, you can become a better surgeon, and you can benefit the patient. Thank you.